Good afternoon, everybody. I'm Richard Bierschbach. I'm the Dean of Wayne State University Law School, and I am absolutely thrilled to welcome you all to the annual Journal of Law and Society Symposium presented in partnership with the Levin Center this year. This year's symposium consists of 3 panels over 3 days, and it's on the topic of opioid paradigms and how the current crisis can and should inform change. It's going to be a great symposium. The panels are going to explore a range of topics, including the motivations and shortcomings in the state's different responses to the opioid epidemic, of how we can move toward more effective policy changes, and issues like healthcare, drug sentencing, and political and legal approaches to the public health landscape surrounding the crisis. I'm really thrilled also to welcome scholars and practitioners from all over the country to this event, including the professors on today's panel from West Virginia University, South Texas College of Law, Elon University, and Emory School of Law. And you're going to hear more about them in a moment. But before you do, I want to thank the organizers of this event, and in particular, acknowledge really the impressive behind the scenes work of our dedicated Journal of Law and Society leadership during a year that's been far from normal. This year, as we all know, has been a hard year in which to find time to organize big events like this, among other things. And so in particular, I want to thank Ben Van Bar and Veronica Walrad, who have just been fantastic. So thank you to you and your colleagues and to your Levin Center partners for pulling this together. So today's panel is on access to addiction medical care. And without any further ado, I'm going to turn this over to my esteemed colleague and one of the country's leading scholars in the area of health law, Professor Lance Gable, to introduce that panel and the panelists. Thank you again for being here, and Professor Gable.
Well, I want to thank Dean Bierschbach for that very nice introduction, and I want to thank all of you for being here today. And by all of you, I mean our panelists, of course, but also everyone who's tuned in for this symposium today. As Dean Bierschbach said, this is a really essential and critical issue going on right now in our country. The opioid crisis has been an ongoing public health problem for many years, and the pandemic has only exacerbated it, made it more complex and more severe. And so what we're hoping to cover today and in the panels that happen on Thursday and Friday this week are some of the important ongoing issues. We're going to explore policy options. We're going to talk about how law affects outcomes and how law can be used, hopefully, to achieve some better outcomes and to really pursue a better path in trying to address this crisis that our country has been facing, that many people have been experiencing for quite some time. And so our focus today, this is the first of the 3 panels, and we're going to be focusing on access to addiction medical care. And what's really exciting for me is to bring these 4 scholars together to have this conversation, because all of them are experts in health law, experts in particular in how health insurance works. As many of you know, health insurance in this country is incredibly complex. There's so many overlapping systems. It's a very complicated situation, and that, of course, applies in important ways to how health insurance affects the ability to receive care and treatment for people who are experiencing opioid use disorders and other substance use disorders. And so without further ado, I just want to quickly introduce our panelists today, and then I'm going to turn it over to them to talk about what I think will be a really fascinating discussion on issues related to trying to remove barriers to having insurance and other support for people who are seeking treatment for substance use disorders. So just very quickly, and I'll introduce them in the order that they're going to speak first. And like I said, this is going to be both an opportunity for them to present some really innovative ideas, but also an opportunity for us all to have a conversation. So after our four panelists speak, we'll have hopefully a lot of time for conversation. And I would encourage everyone who's tuning in today to put your questions in the chat, and we'll try to cover as many of them as we can during our discussion. So today, joining us, we have Professor Tolid El-Sabawy, who is an assistant professor of law at Elon University School of Law. She has written extensively on the opioid epidemic. In particular, we were actually on a panel together just about a month or so ago, where she was talking about some really interesting work that she's done, looking at alternatives to policing and criminalization of drug use behaviors. And she talked about behavioral health crisis mobile response teams, which I think is really fascinating. And today she's going to be talking about a whole range of issues related to health insurance and the opioid crisis. In fact, all of our panelists are. Our second speaker today is going to be Professor Katherine Vukadin, who's a professor of law at the South Texas College of Law in Houston. Her work covers a wide range of things, and one thing that's particularly interesting to me has been her work on ERISA, which is one of the more complicated areas of not only health law, but of all areas of law, and I really appreciate her insights there. Our third speaker today is going to be Professor Valerie Blake, who is professor of law at West Virginia University College of Law. She also has written on a wide range of topics that cover, of course, the opioid crisis, but she's also done some fascinating work in bioethics and reproductive technologies, which I really appreciate and draw on often in some of my own work. And finally, we have Professor Matthew Lawrence, who is an associate professor of law at the Emory University School of Law, and his work covers a really impressive and wide range of topics on health law, including a lot of issues related to health insurance. He also has an article that I have in my queue to read as soon as I have a moment free, that I just saw posted recently, that he co-authored with Lindsay Wiley and Elizabeth McCuskey and Erin Fusey Brown on health reform reconstruction, which I think is going to be really fascinating. So I'm looking forward to reading that. I want to thank all of you for being here and thank all of you for taking the time to spend with us today. And so without further ado, I'm going to turn it over to Professor El-Sabawy for our first presentation.
All right, thank you so much. So I have the unenviable task of trying to explain a big overview, we'll put it that way, of substance use treatment financing. So how do we finance substance use treatment in the United States? And this is going to be a very, very broad overview. And the idea is to give you background information for some of the more nuanced discussions that we're going to have a little bit later. So in the United States, there are many barriers to access for substance use treatment, particularly medications for substance use disorders. But today what we're discussing primarily will be barriers to access that are created because of inability to pay for the treatment. And much of that involves health insurance and how the United States has set up our treatment system. So in the United States, you can categorize the payers that we have as public payers and private payers. Of the public payers, there's two types of ways in which these public payers finance substance use treatment. One is health insurance, public health insurance, and that's programs like Medicaid and Medicare. But the federal government and the state governments also provide grants, block grants, fixed amounts of money that publicly fund treatment as well. I'm going to go over them quickly, then I'm going to give you a little bit more detail, and then we're going to focus most of our attention on private insurance in this talk. So on the private side, individuals can pay out of pocket, and then we also have private insurance. So going back real quick, let's talk about these public payers. So if you look at the blue here in this bracket, the blue, it represents what we would think of as public payers. You see Medicare. Medicare is a federally funded public health insurance plan that is administered by the federal government. That's important because it means that they set the, Teddy says hi, they set the standards federally and there isn't much variation state by state. So if we're talking about medication for opioid use disorder, then we're talking about Medicare's Part B, but there's some cost sharing. We're going to talk about what that is in just a moment. Okay. The other type of public insurance is Medicaid. Medicaid is jointly funded by the state and federal government. It is also public insurance, but it is administered by the state government. And that means that there is great variation in what the state covers and the limits that they put on that. And that's one of our speakers is going to be discussing that. In addition to that, we have what I said before, we're federal, in the other federal block here, that is federal block grants. So those are they call them substance abuse and mental health block grants that are administered by the Substance Abuse and Mental Health Services Administration, but they're mandated by Congress. And these are lump sums of money. When they run out, that's it. There's no more money that comes. And that's different than the cost sharing that occurs in Medicaid. And then again, state and local governments they allocate some of their budget. So if we're looking here, you can see in the public sector, the state and local governments remain the largest payers for treatment. Okay, so let's move on to private payers. Okay, so private payers, we have the individual themselves, they can pay out of pocket. So out of pocket just means that's the money that's coming straight from the individual receiving the treatment. They can self-pay because they don't have insurance, but part of that there's also, even if you have insurance, something called cost sharing, which I will quickly go over in just a moment. Many people have private health insurance. Historically, private health insurance had more limited coverage of substance use treatment. In 2008, the Mental Health Parity and Addiction Equity Act was passed. That was expanded by the ACA, and those provisions went into effect in 2014. Now, this was predicted to greatly change access and the amount of treatment that was covered under private health insurance. But as some of our speakers will discuss a little bit later, that has not actually happened due to some implementation issues. So what these acts did, though, but were very important, was that they mandated that certain health insurances have to provide substance use treatment, and that they have to do it at parity or equally to physical illnesses, meaning there can't be any restrictions that are greater on the on substance use treatment or mental health treatment than there are on physical treatment. All right, so before I end quickly, I'm going to give cost sharing, right? So this is important to understand because this is how access to treatment can be limited even when folks have private insurance. So first of all, people have to pay a premium for insurance. That is a flat fee that's paid yearly. And that's calculated by the insurer, usually based on some type of risk analysis, which, we're going to talk about risk a little bit later. Now, there's some caveats that the ACA put on that and some limitations, but just so you understand, it is a flat fee that people pay yearly, and there is some risk calculation there. Folks also have to pay a deductible. That's the amount that you pay before your health insurance kicks in. All right, this is related usually to your premium. So you'll find that people that have higher deductibles have lower monthly payments. Okay, but this can cause problems, right? Because it can then be very difficult to get care when it's needed. Aside from the deductible, even after the deductible is met, you may have to pay a copay, which is the flat fee paid per service before accessing that service. Then there's coinsurance, which is a percentage of cost that the individual pays. So let's say you have a 10% coinsurance. That means, and your treatment costs $200. That means, or $100 for ease of calculation. That means health insurance pays $90. You pay $10. That's coinsurance. Now, these are limited by out-of-pocket maximums thanks to the ACA. But I think most importantly for our discussions today, it's important to understand that these now all have to be at parity with physical health benefits. Historically, there may have been higher separate deductibles for substance use treatment, different copays, differences in coinsurance. So now after parity, those are the same. Okay. My time is essentially up because I only had 7 minutes, but just there are also other types of coverage restrictions that we're going to get into in more depth that can be used to further restrict access to substance use treatment, one of which is problems with network adequacy, where there aren't enough in-network providers, requirements for pre-authorization that make it difficult to get care, requirements that you fail at one treatment first before you can get another, or treatment limits where they'll only pay for a certain number of visits, et cetera. So that is my quick, super fast 7-minute overview of how substance use treatment is financed in the United States.
Which, by the way, is an impossible task. So thank you for doing an excellent job of really summarizing a lot in a short amount of time. We will turn things over to Professor Vukadin next, or Vukadin, excuse me. I'm sorry, Vukadin.
All right, thank you very much for that warm introduction and for Professor Al-Sabawi's terrific introduction, wonderful overview of what we're dealing with here. So I'm going to go into talking about what happens when a claim for opioid use disorder goes through the insurance process and what might happen to it. So I started writing about ERISA and claims processing after a short time on the defense side of the issue. So I know a little bit about how this goes on the inside. I worked for a Fortune 50 health insurer defending their claims disputes. I then had the experience, and this is karma, of fighting $200,000 worth of denied claims for a family member. It took about a year to resolve them, culminating in a letter to the CEO, the general counsel, and all that sort of thing, which I, as an attorney, felt confident doing. But we have to think about the many people who would not be able to take on something like that. And that's why I studied this issue. So I understand the frustration of people who started to email me looking for help after I published a couple of articles on ERISA and claims processing. They were saying things like, why won't my health insurance cover it? Who can help me? They were just scouring the internet for anything that might help. Then I started to notice that many of the people emailing me had claims involving mental health care and substance use disorder. And the pain out there is very real. Here are 2 quotes from emails I received. Despite assurances from my employer's insurance broker that our plan covers mental health issues, we've met with flat denials. And this is a different one. The conclusion, a denial is contrary to what we've observed and is contrary to the observations of our daughter's treating providers. So these folks are at their wits' end, and it's often their kids need help, and they're just getting denials. So when it comes to healthcare, we often think of those with health insurance as the privileged few. And in many ways, that's true. Having health insurance is, of course, associated with many very good outcomes. Some sorts of care are very easy to access if you have health insurance, but others not so much. So what's the scope of the problem? Well, let's look at who's receiving care for opioid use disorder by type of coverage. So you look here at the orange, which is Medicaid. Then we have 3 shades of blue, but the dark blue is overall. The bright blue is the uninsured, and lowest of all getting treatment for opioid use disorder is the people with private health insurance. And that to me is surprising. So what's going on? Are people with opioid use disorder just not trying to access their benefits? Well, here's another data point. Let's look at a point that came out in a New York State Attorney General investigation. Mental health and substance abuse claims were denied much more often and up to 7 times as often for substance use disorder. So the situation is grim. So why is that? Well, part of the problem is ERISA. So ERISA is going to apply to any employer-sponsored private health insurance. And the principles under ERISA tend to spill over into some of the others as well, because a lot of times you have the same companies processing the claims. It's different, but there is some spillover effect, I think. So let's think about a plan itself. So first of all, the care has to be medically necessary. So if you have health insurance, there's probably this provision in there. Sounds reasonable, right? I mean, what do we want? Unnecessary care? But let's look at that definition. Here's one, it's very typical, and I've bolded some of the ands so that the treatment has to fit every single one of those ands. Why is this particularly relevant for opioid use disorder? Well, opioid use disorder is not generally like something like a broken arm, which happens one day, you get it fixed, and you might have some ups and downs, but you're pretty much on a linear course to getting better. Opioid use disorder often goes along with other conditions. Somebody might get better and get worse. They might feel better the day that they actually go for treatment. And that can be used against them to get their claim denied. So then let's suppose that you file a claim for opioid disorder treatment. And this is loosely based on a case that actually happened. So the company is supposed to look at particular facts and give you a specific reason, but often they don't. It just might come back with something like not medically necessary. You could have been treated at a lower level of care. They just say that in a conclusory fashion. So you look at that definition and think, how do I even attack this? Well, most people don't. They give up because, I mean, they have no idea how to do it. I mean, most normal people would have no idea. People who are attorneys might press on and do it. So if you look at the cases, these are usually very sophisticated people who actually pursue their claims. But let's suppose you do. Well, you've got appeals, first level appeal, second level appeal, and external review. So external review is now required under the ACA for every health insurance, including ERISA covered. You might send letters from your physicians, therapy notes, medical records. Suppose you lose at first and second level appeal. If you persist to external review, actually your odds are pretty good, ironically enough. It can be as good as 50-50 on external review. So anyone who presses on is rewarded. But by then, maybe a year or two have passed. Let's suppose you continue to be denied. Well, then you can go to court. So in court, your claim is going to be looked at taking into account this discretionary clause. These came about in 1989 when the Supreme Court said that these are going to be looked at de novo unless the parties agree to a different standard. Well, guess what? All the insurance companies suddenly decided we were all going to agree to a different standard, which is discretionary review. So now the claim has to be either arbitrary and denied in an arbitrary and capricious way to get reversed. So at the state level, discretionary clauses are considered inequitable, deceptive, and misleading, according to the National Association of Insurance Commissioners. 25 states have banned them, including Texas. And we've been in the news for some tough stuff lately, but we did ban discretionary clauses. So there's that. So how wrong does a denial have to be before it's overturned? It's got to be random. You have to not be able to say it without a loud guffaw. So pretty much, if there are any facts to support it, and remember how complex those opioid use disorder cases are, it's going to stay in place. Well, what if it doesn't? Suppose the court agrees with you and says, well, you win. What do you get? Well, here's the kicker. The insurance company only has to do what it should have done, perhaps 4 years ago in the case of this particular claim. And in the case I'm talking about, the person didn't even win. They just said, well, actually the company's got to go back and give you a better denial than just saying not medically necessary in a conclusory fashion. So as Edward Kennedy said, Senator Edward Kennedy, one of the true champions of consumers in healthcare because his family was so touched by it, he said, some remedy, you can be crippled for life because your health plan refused to authorize a test costing a few $100s, and all you can recover is the cost of the test. Take a look, if you're interested in this stuff, at this Witt versus United Behavioral Health case. It's stunning, and it puts into writing what I was not surprised it was there. I was just glad to see it in writing because you don't usually see that. To conceal its misconduct, United Behavioral Health lied to regulators and deliberately attempted to mislead the court at trial in this matter. These companies are not afraid of courts. You can see cases where they're ordered to do something 3 times and they still don't do it. They're not afraid because they know it really can't turn out that badly for them. Solutions, I'd like a federal ban on discretionary clauses. I'm looking at reimagining the attorney's fees provision. In the meantime, if you get stuck with one of these things, appeal through all the levels, appeal through external review, don't give up, and be loud. And good luck. Thanks very much.
I want to thank Professor Vukadin for that really interesting summary as well, really highlighting some of the major burdens that are built into the system right now. And we're going to continue on. Our next speaker is going to be Professor Valerie Blake.
Hey, I am sharing my slides. Everybody see them? Good? Okay. All right. So first, let me just thank everybody for having me today. And I have to applaud you for having a panel dedicated to this topic. I've sort of made the circuits on opioid policy at a lot of different law schools, and this is the first one that I've seen a panel just talking about health insurance. So maybe it's a personal interest, but I'm excited to see that. The prior speakers queued this topic up really well. What I want to talk about is this question of, let's compare private insurance to the other funders that are in the game to ask ourselves whether or not private insurance is holding up to its end of the bargain. So I'm going to specifically look at private insurance compared to Medicaid, which is one of the other major insurers that is funding opioid use disorder treatment. And then what I'm going to ask is, why is it that Medicaid is outpacing private insurance so much more? And what does that mean for our healthcare system moving forward as we think about reforms? So the earlier speakers have touched on some of this. There's an assumption, I think, out there that Medicaid is the most critical program when it comes to opioid use disorder, and that the bulk of people who have opioid use disorder are on Medicaid. In fact, the truth is that the percentage of people who are on private insurance versus Medicaid is actually fairly equal. So Medicaid covers about 38% of people with opioid use disorder who are under the age of 65, right? Not on Medicare. And private insurance covers 34%. Okay, so Medicaid's 38%, private insurance is 34%. But when you compare neck and neck the performance of those two different plans, what you find is that Medicaid is just sharply outpacing private insurance. So those with Medicaid are twice as likely as those with private insurance to receive drug and alcohol treatment in any given year. And people without insurance, the uninsured, are actually more likely to get treatment for their opioid use disorder than the people who have and pay for private insurance. So we really have to ask ourselves, what is going on in the private insurance system? And is it really measuring up to what we need it to do to respond to this crisis? So why is Medicaid perhaps better when it comes to covering the needs of people with opioid use disorder? Well, what we find when we look at the benefits is that Medicaid tends to be, across the states, more robust in covering more types of benefits. So inpatient, outpatient, medically assisted therapies, multiple different kinds. They just tend to be more generous in covering across the span of the types of benefits and the variety of benefits that people with opioid use disorder might need. And what we also find is that they might be a little more cost effective in what they're doing. So they've been covering a slightly larger portion of the population. They've been covering them more robustly, but they actually spend less money than private insurance on covering these benefits. There's projections that around this year, 2020, Medicaid is going to reach the same amount of spending as private insurance, and onward, that Medicaid will spend more. But when you look at that data, it suggests that Medicaid is potentially doing this much more efficiently and robustly. And just to highlight how important Medicaid is in this crisis, a recent study projected that it may have saved over 8,000 people from a fatal opioid overdose. So Medicaid really is king in this system, not because it covers more people, but because it's doing a better job. So why? Why is Medicaid outpacing private insurance? This is a good topic to unpack more in the discussion, but I'll say just a couple of reasons I think it is. One, there's no cost barriers to accessing Medicaid. If you're on Medicaid, then you can walk in and get care and you don't face any of those cost sharing things that Talib had talked about. There's greater public accountability. People pay more attention than they do to what private insurance is doing. There's less discrimination in the system. And I'd love to talk about this more, but frankly, there's more skin in the game for states to be funding this robustly because the opioid crisis is affecting their other budgets as well, right? In overdose and policing and child welfare, in education and other healthcare costs. And so they have a real vested interest in trying to handle this crisis in a way that private insurance maybe does not. Okay. So what I would really like to see moving forward is that we really critically think about this disparate efficacy of Medicaid versus private insurance as we potentially reform our healthcare system. I think there's lessons here for broader health reform. So one, and this is a more small solution, is for now, before we get to some wide scale health reform, probably our best thing we can do is expand Medicaid. So we've already expanded Medicaid through the Affordable Care Act, but it was optional. And there's 12 states that are holdouts that have elected not to expand Medicaid yet. The recent COVID legislation is actually still just being voted right now on the floor of the House. And in that, there is actually a provision to address this issue to try to entice the states that are holdouts into expanding. So it's a nice bargain for them. Basically, what it says is we're going to cover, the federal government will cover 90% of your costs for your expansion population, which is what everybody gets if they expand Medicaid. But also for your regular Medicaid, for the people in your state who are already on Medicaid, we'll cover 5% of your costs. So it's a pool of federal money that they're putting out there to try to entice people, to try to entice these holdout states to expand. If we see greater Medicaid expansion across the nation, then we'll see more uninsured covered with access to care. And we may see some people who are in the private market now eligible for Medicaid, which is working much better. And then in my last couple minutes, I'll just say, what does this mean for a bigger health reform? I think we need to really think about the fact that in a major healthcare epidemic in this country, our private insurance system has not been measuring up to our public insurance system. And what that might tell us is that public insurance certainly is a better path forward when it comes to worrying about the health of the public. And there's lessons to be learned if we're going to think about Medicare for all or a public option. So one thing to kind of consider is that the opioid use disorder story and the failures of the private insurance market are a valuable story to inform healthcare reforms moving forward. But one of the things we really need to do is make sure the public understands this story, understands that Medicaid is actually the superior benefit and is performing better, because there seems to be a public sense that private insurance is the best in all things. And if we elect something like a public option, people might not elect the public option if they think that their private insurance is actually better. And so this is partly informing the public to make sure they understand that Medicaid really is a superior benefit when it comes to this particular line of healthcare needs and potentially others as well. So I'll wrap there, and I'd love to have questions when we get to the end.
Thank you, Professor Blake. I also want to remind everybody who is watching that if you do have questions for any of our panelists or for all of them together, issues you want to see them discuss further in our discussion portion of the panel today, please put your questions into the Q&A box and we will try to address them in a little while. Our last panelist today is Professor Matthew Lawrence, so I'll turn it over to him. Take it away.
Thank you, Professor Gable. And I want to thank everyone in the audience. It seems like we have a great group of people interested in this really important topic that I've been loving listening to my co-panelists talk about. It would be hard for me to pick 3 better experts to hear from. So I almost want to just pass on my time, but I will present as promised. And what I'm going to do is talk about the underlying problem with why health insurance sometimes is a barrier to coverage for substance use disorder, and then and talk about one variety of solution to that problem. So I want to start with the underlying problem. You've been hearing about it, but just to lock it down, health insurers have strong incentives to discriminate against providing coverage to people with substance use disorder or to anyone with a chronic illness. I don't mean this to disparage health insurers. This is a product of our system of providing healthcare coverage through insurance and relying on profit motives, and insurers need to maintain revenues in order to process our system. We created this system, and it creates an incentive to discriminate against the sick. There's also stigma involving treatment for mental illness that contributes even further to barriers to coverage in insurance plan design and implementation. A picture version of this point is you'll hear about in insurance lemon dropping and cherry picking. So let me just say what I have here. If you took high school biology, you learned about cells. And a cell, that's my circle there, is the cell wall. It has to keep out bad things like coronavirus and try to let in good things like potassium and sodium. And that's a risk pool. Insurers must balance their risk pools, meaning they have enough healthy people paying premiums to cover the claims of sick people, which means they need, I have H for healthy person and S for sick person. And the health insurers need a good mix of H's and S's from an economic perspective in their risk pool. As a result, they engage in what economists will call, or health law professors will call, lemon dropping. They'll try to discourage sick people from enrolling in their plans, or they'll not worry about losing sick people, because a sick person, imagine somebody with diabetes or, God forbid, cancer, that person pays a certain amount in premiums each month, but then they incur a lot in claims. So the insurer loses money on that person and is economically better off if they're not in the plan. And then insurers also engage in cherry picking. They try to attract healthy people. And insurers have several different tools to try to discourage enrollment by the sick and encourage it by the healthy. They can do it in how they design their benefits. They like what services they cover. They can also do it in how they administer their plans. Like Professor Vukadin was talking about, denying claims, being a pain when denying claims. That who quits an insurance plan because it was such a pain in processing claims? Sick people, not healthy people. So you can, what's called risk selection by design. And then sometimes there can be exclusions in premium underwriting. Again, this is just a product of kind of those economic incentives that face insurers. So that's our underlying problem. And there's different categories of solutions. We've talked about the parity law, benefit mandates, you can have appeals. And now I want to talk about one other solution now. So, when I do this very quickly, I want to encourage us to think systemically about how to solve this problem. Because as Professor Vukadin pointed out, even appeals, who's going to appeal? Somebody who has the wherewithal and the resources to appeal. It's not an equitable response to this kind of a problem. A sick person who's dealing with a mental health issue or opioid use disorder is not well positioned to appeal their claim all the way through to the CEO or something, as she pointed out. So thinking systemically about the problem. Risk adjustment. So risk adjustment is a way of tinkering with reimbursement for insurers that's common in public plans. Medicare, Medicaid, 75% of Medicaid enrollees are in a managed care plan that's run by an insurer. So Medicaid, Medicare Part C, which is privatized, the Affordable Care Act. The government monkeys with insurers' reimbursement to try to counteract their incentive, their economic incentive to discriminate against the sick. And simply put, the insurer gets more money if they enroll a sick person and less money if they enroll a healthy person. So Medicare Part C, if an insurer enrolls somebody with diabetes, they get an extra $3,000. And the goal is that they become indifferent as to a person's sickness. And they now compete on things like efficient claims processing and, providing you the benefits and things like that. And so I have it drawn on there in my risk pool as tiny carrots and sticks. It's if the sick person now comes with a carrot, the healthy person comes with a stick. And the goal is to start to somewhat mitigate that problematic incentive. There's a lot of limitations to this. It's only in those publicly administered plans, Medicaid, Medicare Part C, and the ACA. It also is very hard to do well. And here's the rub. It's currently done. It's problematically done when it comes to mental illness and substance use disorder. So let me finish up by saying there are some prominent economists, and I cite them here, who have written specifically on risk adjustment to promote treatment for substance use disorder and mental health. And they said, there's things we could be doing. We should be doing those to get even better, to make Medicaid even better for substance use disorder, to get Medicare even better. And here I cite them here. So these ideas are out there and ways to be better. And then my legal point is, first, state and federal regulators, that's up at the top. Legal point 1, state and federal regulators could use risk adjustment more effectively to promote treatment for substance use disorder. And then second, something very concrete to go home with, the Affordable Care Act required Medicare to look at using risk adjustment more effectively to treat mental illness or promote treatment for mental illness. I have the Affordable Care Act on the screen. It said the HHS must evaluate and revise the risk adjustment system periodically. And I've scoured, and all I can find is a document from 2011 that to me does not evaluate and revise the risk adjustment system. It fails to comply with this statutory mandate. And then since 2011, I've seen nothing. So from where I'm sitting, and I may have missed something, although risk adjustment could be used to more effectively promote treatment for substance use disorder, and although the Affordable Care Act requires the HHS, Department of Health and Human Services, to look into that, it is not doing so, which is a reason to focus in this area. And I'm sure there's lots of questions. There's many broader points. I'll just kind of close again by saying I think it's beneficial to think systematically about solving these. And we've heard a lot of great ideas today, like expanding Medicaid. Looking forward to the Q&A.
Okay, thank you, Professor Lawrence, and thank you to everyone. We've had such an interesting set of presentations so far, and we now have lots and lots of time to have a discussion about these issues, to get into some more detail. I want to encourage our attendees again, if you have specific questions or if you have very general questions, please put them in the Q&A box, and we will try to get to them in our discussion. I see there are a couple of questions in there that I'm going to get to in just a second, but my sort of initial, I guess, big picture question, and it kind of builds off of the comment that Professor Lawrence just made in his presentation. We are thinking about systemic problems that are baked into the system. They're built up over time because we have such a complex health insurance system. And obviously, some of the potential solutions are easier to implement with regard to the public insurance programs. The private insurance is probably a bit harder to influence, although there could be regulations that more tightly regulate what they're doing as well. And I guess my first sort of big picture question is, we're at a place right now where we have a new administration. Obviously, the Recovery Act, has some provisions that are geared toward strengthening the ACA, incentivizing states to expand Medicaid, some of those kinds of big picture policy questions, which will also serve to hopefully increase access to insurance coverage for people with opioid use disorder. And I guess my question is, a lot of the suggestions that you've all made already, and that we'll talk a little bit more about in detail, are big systemic changes that will affect our health insurance systems broadly, and will have the byproduct of affecting access to treatment for people with opioid use disorder. Are there provisions, I guess, that we should also be considering simultaneously that are more targeted toward that population of people, or is it just is our best policy just to strengthen our entire system through all of these different approaches that you've already alluded to? And I guess jump in. Yes, go ahead.
It's hard for me to look at my pen. I'll just say something within that risk adjustment system. Some of those economists I pointed to have very specific substance use disorder focused proposals. For example, I said that an insurer gets more money if someone has diabetes. How do you know if they have diabetes? You look through the medical records, there's actually a lot of fraud, waste, and abuse. It's hard to do. But what the economists have said is for substance use disorder, if someone's prescribed medication-assisted treatment, that fact should automatically signal they have substance use disorder, which it doesn't yet, and then get the insurer additional reimbursement. The counter argument is that that would give an incentive for the insurer to try to get their enrollees medication-assisted treatment because they get more money for that. But what the economists point out is that that is a good thing. We want somebody out there helping people get medication-assisted treatment. So that's an example of a very nitty-gritty, specific proposal focused on this issue.
I think that
No,
sorry,
go
go
ahead.
ahead.
No, go ahead. Go ahead.
I was just going to say that, we're going to need to address network adequacy. That is a big issue. Even if you do have the financing to pay for it, we need to have the providers that are willing and able to prescribe the medication, since this panel is focused on medication for substance use treatment. The reasons, there's a number of reasons why there's network inadequacy. For private insurance, sometimes it's because they pay significantly less for mental health or addiction providers than they do for physical providers, physical treatment. Part of it is because of the federal regulations that put more onus on people who want to prescribe medications for opioid use disorder, substance use treatment. So I think that needs to be addressed as well, because otherwise, if we don't have people to provide the care, just fixing the treatment itself, the payment system itself isn't going to do much.
Yeah, I mean, another thing I would put in that's opioid use disorder and SUD disorder specific is covering more alternative pain therapies. So there's been a lot of studies, one recently in JAMA looking specifically at back pain, but there's been some other studies that suggest particularly private insurance has been unwilling to adequately cover non-opioid treatments for pain. And part of that goes back to a lot of what Professor Lawrence was saying and just the profit motive, because a lot of times these alternative pain treatments are much more expensive, at least in the short term, than opioids, which are quite cheap. And I'm talking about things like physical therapy, a couple of weeks of physical therapy compared to a course of opioid pills can be a much better option for people in some circumstances, but private insurance doesn't normally have the appetite to spend that. So, we could certainly look at mandates and greater regulation around that issue. I would also say, so I think there are the kind of more narrowly tailored SUD specific solutions. But what I'd also say is I worry there's no appetite in Congress to touch this issue, SUD specific or broader. So we've had the last two pieces of major federal legislation on opioid use disorder didn't touch the private insurance market at all. They made some minor tweaks around Medicaid and earmarked some funds for the states to try different models. But, I think that there's knowledge that the private insurance market hasn't been performing, and there was nothing in those laws to try to make private insurance perform better. This most recent COVID bill that's hopefully about to be passed, it encourages broader access to the private market, but it doesn't change the guts of the private market. It doesn't change what it's covering or how good of a job it's doing. So, now you have access to care and maybe you're not going to get it because of the cost sharing and the lack of benefit coverage and the lemon dropping and all of that. So, part of this is recognizing the problem and hopefully trying to find an appetite for small and big change.
And just to agree with Professor Blake, thinking back to when the ACA was passed, I dug through the websites of some of the lobbying groups, and they don't still have these letters on there, but for a while they had letters that they had written to Congress, and when Congress was thinking about changing something like ERISA preemption, and it would be signed by the entire Fortune 100, just all of them. So it's kind of tough to go against that unless you really want to, unless you're a Ted Kennedy or somebody who's of course no longer with us. So I think that's exactly right. It's a tough sledding.
Yeah, well, thank you. I think that was those were really insightful points, and I want to try to jump into the Q&A here. There are a number of questions and comments that people put in, and so I'm gonna try to get to all of them. But there are a few that relate to what we were just talking about. So one of the commenters notes that as an MAT provider, that this person sees a substantial reimbursement through Medicaid for OUD, and that the Medicaid, and it's great that the Medicaid sets a standard that private insurance should follow. However, it's extremely difficult as a provider to not be able to continue care if patients are not able to pay, or if there are copays or some of the other cost-sharing modalities here. It's extremely cruel and disheartening to place high-risk patients on medication like Suboxone that they may be on for life and have them cut off because insurance issues or unpaid bills, which is highly likely to happen in this high-risk population. And so, that I think that reflects, some of these challenges here, especially when you're talking about this differential in access between the different kinds of plans. Another commenter says that one of the issues that exists is quality of care for certain higher levels of SUD treatment, especially OON treatment that is heavily advertised, or drug testing, notably in Florida, or for non-evidence-based wilderness treatment in Utah. Not a payer issue, but rather a provider issue. Do you think this area can be better regulated or legislated? Any thoughts about that?
So, that's a great question. I've looked at some model laws that have been proposed or given to various state attorney generals recently on regulating substance use treatment facilities, particularly residential treatment facilities. I think a couple of points on that, though. From what I could tell when looking at who pays for residential treatment, private insurers tend to try to get out of paying for residential treatment as much as possible, even without the issues related to quality of care. So I think that that's important to note from a payment perspective. I don't know that that's driving a lot of the issues that we're having in the private market. It could be, but it doesn't seem to be one of the major blocks right now. So it's difficult for a number of reasons, because states seem to be unwilling to credential a lot of these treatment programs, or to have standards that make it so that these programs communicate the type of care that they're offering. So for example, they might say, we offer substance use treatment, but that involves, really like a luxury retreat, right? And they don't offer any medication for opioid use disorder or any evidence-based treatments, right? So there are moves towards doing it, but there are lobbies that are against it, and hesitancy at the state level for state governments not having the finances to be the ones that are looking at credentialing these places. So there's been moves to trying to get them to do voluntary credentialing so they can use it in their marketing, and there are private groups that are trying to credential these treatment programs. So that's what I've seen as far as credentialing and regulating substance use treatment providers.
Okay, thank you.
I'll just say,
yeah, go ahead.
On the provider who described how basically the inherent churn in private insurance makes it really difficult to put somebody on a medication that they then may have to drop off of. It makes me think about how with HIV, we have the Ryan White program as a kind of a dedicated source of coverage, as a backdrop or as the primary source of coverage, and think about how nice it would be, perhaps, if there were something like that for substance use disorder that would be a guaranteed backstop, that you wouldn't have to have that kind of a concern. That would obviously take legislation, I would think federal, in order to help with funding, unless states were able to cobble together like a back end reinsurance kind of market to cover, pool to kind of provide stability there. It seems like a really important point.
Yeah, I mean, to echo off of Professor Lawrence's point, that was something that I was thinking to the first guest's question. We kind of talk about it in terms of public financing and private financing, but when you come at it from the individual lens, it's not so simple as private financing, right? Because in any given year, maybe you have the exact same job and the exact same insurance package, but they change the benefits in some way, or they put a different cost sharing. Maybe you switch jobs. Maybe your employer switches the insurance company that they work with. Maybe your provider leaves and a new one comes in. There's so many different cogs for any single individual in any given year, and it cycles through this annual process. And opioid use disorder is not something that's necessarily cured overnight, and so it's not uncommon in the private market to see people sort of have to stem the tides of that change, and it can really affect what access to care is available to them at any given time. And most people are just not equipped to be able to inform themselves on what their insurance covers in any given year. And it's, to Professor Vukadin's point, it's not particularly easy to figure that out. You get a denial and then you kind of run up against that and you say it must not be covered, and I'll go without. And so the kind of inherent complexities of it are also something that I think the private market has going against it when you compare it to the public.
Yeah, go ahead, Professor Vukadin. You have a, okay. There are a couple of questions. I mean, just an additional comment on that last point. I think the notion that we frequently see that sort of encourages the market-based approaches to, shopping for health insurance, it's obviously a frequent point that drives some of the discourse about health insurance, but obviously the reality here is that with regard to any kind of condition and any kind of coverage, it's very difficult to shop across multiple plans, even if you have the opportunity to do such a thing, and you have any say in that, it's extremely challenging to figure out what's covered and at what rates, and to try to predict those types of things just through trying to gather information. The system is so complex. There are a couple of questions in the chat here that have asked about peer recovery coaches for substance use disorder and insurance coverage for that kind of treatment approach. One questioner says that making peer recovery coaches for SUD more available does not seem to be covered by a Medicaid CPT code. Private insurers are hesitant to reimburse these peer recovery services. What steps can be taken to further that goal? And there's another comment that mentions that that they're trying to get peer recovery services covered and reimbursed with private insurers and by state agencies to try to expand use. So do any of you have any suggestions or ideas about that expansion of coverage, and also I guess other non-medication services that might be covered, and how that might be accomplished?
I
know West Virginia. So, I mean, one thing on the Medicaid side is sometimes that can fit in under what's called a 1115 waiver, which is effectively a waiver to say that the state wants to cover certain benefits that the federal government doesn't require that they cover. And if they can get an approval from Centers for Medicare and Medicaid Services, then the federal government will help pay for those expenses along with the state, and sort of make that a regular part of the state's benefits. And so, I do believe West Virginia, in its 1115 waiver, included some support for peer recovery. So, you might look to see if that is becoming a broader trend nationwide in state Medicaid agencies. I don't know if people have thoughts on the private side.
Yeah, I haven't seen anything like that. I mean, I haven't gone through plans to look for something like that, but it has a feel of getting denied to me. But just because they usually are looking for, they'll say, well, the session wasn't led by a credentialed person or something like that. I've seen that kind of denial. So for all these specific things, I mean, I think if people contacted their elected representatives over these things, it would get on the radar screen, because I don't think that happens enough. And that's a lot of what prompted the mental health parity laws, is personal experience of our elected representatives, and then also hearing from people. So I think if we were all a bit louder about this, I think that would help.
As far as peer recovery specialists being paid under Medicaid, it varies significantly by state. Some states actually credential peer recovery specialists. So for example, in North Carolina, a peer recovery specialist is a statutory term, and you are credentialed, and that has then made it so that they can bill Medicaid in many states. Aside from that, on the private side, the way that historically it's been done is peer recovery specialists are included inside a recovery treatment center. And so the treatment center itself bills, and what they bill for are the treatments that are provided in that center by these peer recovery specialists, but they're kind of bundled. So you're not billing specifically for a peer recovery specialists. That's the only place I've seen it in the private sector. But yes, that helps me.
So another issue that's come up in the question area, sort of moving back to thinking about medication as treatment. One of the questioners asks, as a community pharmacist, about what had occurred 2 to 3 years ago with private insurers in response to the opioid epidemic, where there was a limitation of the amount of doses that could be dispensed or prescribed, and whether those kinds of restrictions were something that could be addressed through insurance regulation or otherwise through some of the regulatory structures that we've been talking about. And I guess it sort of connects to a bigger picture question, which is that obviously there are all these different considerations that go into any. We're focusing on primarily on the payer side and on trying to expand access. But that's happening in the context of all sorts of other initiatives that are going on to respond to the opioid crisis, including some that might have counterproductive effects in terms of access because of concern about overprescription, concern about abuse, concern about or overuse, I should say, and concern about people gaining access that try to limit access, not through limiting the ability to pay for that access, but limiting just the ability, putting hard restrictions on what people can gain access to through pharmacies or through prescriptions or through other mechanisms. So any thoughts about how that plays into this discussion?
I'll jump in and say that one of the most frustrating things observing policy in this space is the lack of coordination, particularly that sort of example, which we've seen repeated, of well-meaning efforts to taper long-term prescriptions not being matched with provision of alternative care for those patients, and then people are driven into the illicit market. And I mean, that sounds simple to say, but it's tragic and has happened in a number of different places. This has been a great discussion, and we've been focused on health insurance. That question pushes that, hey, everybody should sign up for the other parts of this symposium, and there needs to be mechanisms to coordinate. And that's another thing going on in the background is the regulatory structure between ERISA, Medicaid, Medicare is so fragmented when it comes to insurance. And then it's even further fragmented when it comes to all the other interrelated areas here. And to my lights, but I'd be curious what my co-panelists think, to my lights, there's not a brain in the middle keeping track of what all the limbs are doing. And you get results like that.
Does anyone else want to jump in?
There-
Oh, go ahead.
There's other kinds of examples of sort of counterintuitive measures, so I just saw anecdotally in an NPR article that providers are having to, I'm going to totally botch the kind of details, but providers having to fill out certain paperwork or certain charting on electronic medical records in order to support longer term prescriptions. And so, they're giving patients the largest sum of opioids that they can possibly give right out the gate so that they don't have to handle that kind of periodic update. So that's one of those things where it's like, we're trying to reduce the amount of opioid prescribing, but in fact, what we've done is sort of incentivize providers to give more pills right out the front. I agree. We had sort of this kind of backlash where maybe we went too extreme and that we just didn't prepare for adequate treatment to cover the people who were suffering from the addiction and alternative pain treatments when we ripped away the opioid treatments. So, in both of those sides, I think there have been failures on the financing and the delivery side. And unfortunately, what we've seen from that is the movement towards heroin and fentanyl and infectious disease cropping out of that. And that's ultimately a problem for the state governments and private insurers.
Any other thoughts about that one? Okay, another question that came up in the question and answer box that raises a slightly different issue, but one that also has been driven to the forefront during our pandemic response is the impact of telehealth services. How has the greater availability of reimbursement for telehealth services affected access to opioid use disorder treatment, and also, what should we do in approaching that going forward? Obviously, systemically, there are a lot of advantages to having greater access to telehealth and greater ability to pay, through insurance for those services. And I guess curious what you all think as to how that might, how it has played out during the pandemic and how it might play out in the future.
Well, so far the studies show that it has improved access and has not detect in a way that we can detect increased diversion. So it seems to be, that was the biggest concern about having remote sessions particularly for medication for opioid use disorder, was that the medication would be diverted. And so we now know, we have evidence now that that's not the case, and it is increasing access and treatment retention is good and so forth. So hopefully, we kind of had a natural experiment, and the hope, because it greatly increases access to care, particularly for rural populations as well, that may not have an MOUD provider in their area. So on that front, seems to be some good data.
Yeah, and you think that might help on the insurance side, because that has to be cheaper if you're not paying for a building. So that might, because I think that's part of the reason the insurance companies are so sticky about it, because it is just really expensive. So that might be something really good on all fronts.
I'll just flag, there's an article from the GW Regulatory Studies Center from a couple of weeks ago. It's extending pandemic flexibilities for opioid use disorder treatment. And it's a nice overview of some of this that's pretty optimistic about the usefulness of that.
Okay, so I have another question that actually has a Michigan specific example, but I think raises an interesting issue that might be more broadly applicable as well. So the questioner states that currently physician's assistants and nurse practitioners provide mental health and SUD coverage all over Michigan. However, they're not part of the mental health code. And there's currently some legislation that has been introduced, I guess, to include that coverage in the mental health code. But the concern is that by these practitioners providing coverage not being included in the code limits insurance reimbursements and incentives provided to other providers like therapists and physicians, et cetera. And so it raises the issue of not only what is being paid for, but who can actually receive payment for their services from the provider side. So are there, that obviously raises an interesting other dimension to this conversation. So what are your thoughts about how we can ensure that anyone who's providing services has the opportunity to receive reimbursement for them?
I always have something to say, but don't want to jump in. I'll just share that I personally vary between 2 points on this. The first is that any source of treatment that a person's trying to receive and that someone's going to provide, that they should have access to that. And then the second, which I'll sometimes hear from the medical community, is that there are some types of treatment that might actually be problematic or take up time that could be spent on other forms of treatment, and that someone should be there to sort what sorts of treatment should be encouraged or not. That gets to medical questions that I don't have the expertise to opine on. I can say that health insurance, in theory, helps to sort which treatments are allowed and which are not allowed through utilization review. And one of the big problems with insurers' incentives is when they are not doing their sorting, thinking about the medical best interests of the patient, but instead thinking about profit and what's cheaper and things like that. And so a big goal of regulation in this space, as I see it, is if insurers are going to play that role, we could debate whether they should, but if they are, we want them to be thinking about what the medical professionals would say they should be thinking about, which is evidence-based treatments that are going to be effective. We don't want them thinking about their economic bottom lines when they're structuring their systems.
Yeah, I mean, anytime you sort of talk about expanding the field of people that can provide services, you also run up against professionals who that is not in their interest. So I mean, historically, we've seen physicians lobby against broader expansion of scope of practice for other providers. I don't know that that's as much of a concern in this field where, we tend to have an insufficient amount of providers. But, if you can get state medical boards, the American Medical Association, the American College of Physicians, if you can get professional societies of physicians to advocate for this, I think it goes a long way at the federal and state level to suggest that this is a needed solution to the crisis, and that that doctors won't stand in the way of helping other providers to be more engaged.
So another issue that's raised in the question box here, and this is a slightly different topic, but one that again is looking at other alternatives to improving access. The questioner notes that states and insurers have come together in the context of tobacco cessation programs pay for research-based treatment and medications for people who want to stop using tobacco, and including 800 counseling numbers. And the questioner asks whether this is a model that research-based model for addiction treatment that can be used with regard to substance use disorders. Is this something that is an opportunity, or are there other related kinds of approaches that might not necessarily be directly connected to payers, but might also be opportunities to expand access to treatment? Okay, so nobody seems to be enthusiastic to jump in on this one.
I don't know if I can speak for all of us. That sounds really terrific, given insurers' current incentives and political environment. We don't have it, so it's frustrating.
I mean, what I would almost more like to see is that this, we've touched on this. We didn't get into it in much detail, but the laws on the books that govern private insurers aren't that bad in this area. They're especially the parity law. It's pretty clear that these benefits should be covered. And what has happened is that in practice, they're not by private insurers. And that has to do a lot with enforcement and monitoring their compliance with the parity laws. And so, if I were going to dream up a way to have greater kind of state and private insurer involvement, it would probably be that state officials were a little more aggressive in monitoring their state benchmark plan and their state plans generally for whether they really comply with the ACA and the parity law and things like that. And maybe you kind of get some research dollars or something else as the carrot to that, along with the stick. But that's where I would kind of like to see, before, because we do have treatments that we know work. They're just not getting into the hands of people.
I think it's important to acknowledge kind of the historic reason why we're here. There's been a long battle in addiction treatment history between the addiction medicine specialists in 12-step based recovery treatment centers that has put us in the position that we are in today. A lot of, things have gotten better. And so I think that we're moving in the right direction, but this is partially due to, historic policy path dependency that we have just been on for such a long period of time. And we're disentangling things, but it was a long way in the making. So it's going to be a long way in the fixing, I guess.
Yeah, just jumping off from that, I think one thing that we haven't talked a lot about today, but obviously it provides the context for all of these discussions is that history and the long history of stigma for drug use, and especially especially illicit drug use, but even more broadly, people who are using pain medication. That and people who have a substance use disorder. I mean that traditionally has been, those have been groups of people who have not been viewed favorably in our society, have not been supported by policymakers by and large over the years, and so some of the recent responses to the opioid crisis have been possibly less stigmatizing than some of the earlier reactions to other similar types of public health problems. But I think there's still a long way to go, and there still is a lot of stigma. To what extent does that play into these policies? And I'm particularly interested in does that affect, or how does that affect when we're talking about things like insurance coverage, which is often examined in a way that's more focused on markets and costs and that sort of thing. But obviously, society's willingness to support public health initiatives is driven by those underlying factors about how society treats people who are experiencing the public health problems.
I mean, I think it's incredibly important. And just reading about the mental health parity law and how our leaders became so much more interested when those things were touching their own families. I mean, I guess I sort of naively thought that they were sort of looking out for everybody and maybe, taking the big picture into account, but they're like everybody else. When something touches them, it matters more. And now people are hearing about, well, this professor had a teenager who got into opioids, and once it touches people more, I mean, I guess that's just human nature, but I think it's incredibly important. I really do.
Yeah, I mean, you can look at the history of the discrimination in the private insurance markets, and it often falls on socially stigmatized groups. So, if you go back and look at the history of HIV and AIDS care, we had lots and lots of litigation where people who were HIV positive were subject to benefit restrictions and higher cost sharing, higher premiums than their counterparts, even though there wasn't any evidence that the cost of their treatment was more expensive than conditions that we regularly cover in the private insurance market. So we don't see a lot of debate about, does private insurance cover heart disease, even though that's one of the most expensive conditions in the country. We don't see a lot of debate about cancer treatments, about certain pediatric conditions. So in a lot of ways, it's always good to look at what the benefits are that are being excluded, which groups are kind of the out groups in insurance, because they're often the out groups in society as well.
And this isn't new, and my co-panelists have heard this story before, but I will talk about how the nation's first opioid crisis in the late 1700s, mid 1800s, right? We dealt with different target populations, different people that were affected, and depending on who was affected by the crisis, it changed the policy responses even as early as 1865, right? So if it was persons of color, Chinese immigrants, Black men who were using the drug, the reason for drug use, even by medical professionals, was that it was attributed to deviancy, right? The person was a deviant, and there's nothing. What do we do with deviants? We lock them up, right? Because we don't use medical treatments for deviancy, for poor moral fiber. But when it was women, particularly white middle-class women in the South, that were addicted to morphine, the response was to allow them to go to doctors to have medically managed treatment, even that far back in our early history, right? As the target population shifted and we started having more working class folks that were using drugs, the drug war began, right? And again, we started criminalizing and removing it from medical speak. I mean, there was a point in time where the predecessor to HHS essentially called addiction a psychopathy, right? So what do you do with what do you do with a sociopath, with a psychopath, right? You don't give medical treatment, you put them in prisons. And so we have this long history of just structural and institutional racism that has played out in the addiction space and has really affected how we treat the problem.
Yeah, and I guess just following up on that excellent point, does the fact that, I guess, is there an opportunity now to either address or begin to overcome some of those historical legacies of discrimination and racism? We are grappling with that as a society more openly than we have before. And obviously it's coming in the context of all sorts of other challenges that we're facing right now. But I wonder if, continuing to highlight the connection in this context as well is something that I think is an important strategy, and will also, I think, reinforce some of the other things that we've been talking about that will improve access going forward as well. Now, do you agree?
Yeah, well, but it goes to, there was somebody in the chat that put in a comment about, how we keep talking about opioids, and that's partially because the panel is about medication for assisted treatment, and we don't yet have, as we don't have as many medications that can treat other types of addiction. But the narrative is focused on the opioid use disorder, despite us having had a methamphetamine epidemic in this country for at least 6 or 7 years now, that has flown under the radar because we're so focused on the crisis, the drug type that meets a certain class and socioeconomic profile, right? But what's also interesting, and I think we need to highlight this, is really important, we kind of glossed over it, is that there has been more lobbying by pharmaceutical companies in this space, and that actually there has been some work on the Parity Act that showed that the folks that lobbied for the 2008 Parity Acts received heavy monies from pharmaceutical companies in this space that are producing these medications for opioid use disorder. So I write that I also think that we're talking about it as a health problem more, because there's a lot more health actors, like big pharmaceutical lobbies, that it's in their benefit to talk about it as a medical issue.
So go ahead.
I was just going to add that, seeing multiple federal pieces of legislation passed targeting this issue does give me optimism. And they were, mostly bipartisan, maybe 1 or 2 people voting against them. But again, the insurance piece just seems to be somewhat intractable because it just wasn't addressed. And so, I worry that question of access and funding is bigger than opioid use disorder, bigger than substance use disorder, and goes to the very heart of our healthcare system. And I worry, I hope we'll see change, but I think that that's a tremendous piece of this problem, and I don't know that we'll get bipartisan agreement around it as easily as some of the other changes that we have targeted.
There's a huge insurance lobby there that has just been for years trying to prevent this. So that's going to be what needs to be overcome, is the insurance lobby, I think.
Yeah, so I see we only have about 3 minutes left. This time flew by, and it's been such an interesting conversation. I wanted to give each of you just a last shot at, quick summary, take-home points, things that we should be focusing on going forward in our last couple of minutes here. And you don't have to, but because we've covered so much. But if anyone has takeaways, please share them now.
I'm going to go ahead and give my time over to somebody else, because I've spoken a lot today. So.
Well, I was just going to remind everybody that if you run into anybody who's battling a denial, do not give up. Fight through every level of appeal. Take that external review. It costs like $25. It's well worth it. So tell everybody, keep fighting. Do not give up, and be loud. Contact your representatives.
And I'll just add a point on information, that same point. It's so hard to even understand what's happening in terms of insurers processing these claims. You can file parity complaints with states, and we do get these stories that trickle out. What we'd really like to see is audits of insurers and how they're performing their claims processing, and to actually get some good information out there about how sick people are being treated. And that is a first step. So any of you who are providers, I think if you encounter frustrating situations, I would find the relevant regulator, whether it's federal or state, and let them know, because often they're understaffed and have no other way of finding out.
Recognizing that the private insurance market is maybe not rising to the level we need it to, I think is an important step in moving forward with bigger health reform in the future.
Okay, I want to thank you all so much. I want to thank my panelists for being here today and sharing their knowledge and wisdom and insights. It's been a great conversation, and really grateful to them for being here. I also want to thank all of the attendees, those of you that are still hanging on. I know some people had to go to class, and other people probably have other meetings, but I want to thank everyone for being here today, and want to encourage you to come to our panels tomorrow and Friday, both at noon, where we're going to be continuing to have more conversations about the opioid crisis and other policy issues that we can address in trying to to mitigate the harmful effects of that crisis. And so I want to thank everyone. Stay safe and have a great day.
Thanks, Professor Gable. Thank you so much.
Thank you. Take care.